Welcome again to Baltimore. It's very nice and sunny here, and we are going to be talking about bladder cancer and specifically about how to minimize the impact via organ preservation. My name is Armine Smith. I'm part of Johns Hopkins University, part of Brady Urological Institute, and a Greenberg Bladder Cancer Institute. So we are going to start with the basics and kind of progress a little bit more towards the topic of the presentation. So basic anatomy, kidneys located in the upper part of the abdomen. Urine is collected and brought down to the bladder. The ureters, the renal pelvis ureters, and the bladder are all, as you'll see, line up with the same type of almost anatomy. And just to zoom in on the bladder also has distinct anatomical sites that we use when we treat the patient, when we talk about the bladder cancer, so it's a bit of an interest. The top of the bladder, or we call it a dome of the bladder, the ureters come in and join the bladder and the openings here, ureteral orifices. This is all kind of convene in the part of the bladder called trigone. The trigone is the part that has the most nerves and the vasculature. We also have the right wall, left wall, back wall, and the front wall. This is an area that's called the bladder neck. And sometimes the tumors can form here, and then the urethra traverses and brings out the urine out into the world. To look at it in a little bit of a different way, again, you see the kidneys and the ureters joining the bladder. Women have uterus in the vicinity of the bladder. Men have the prostate, kind of adjacent to the urethra. And the layers of the wall are composed of the transitional urothelium, or urothelium, as we call it. And the tumors can form here and penetrate deeper. Right behind the urothelium is the connective tissue layer, or lamina propria, and that is followed by muscle, or detrusor muscle, as we call it. And then there's the fatty layer, or the adventitia, that surrounds the bladder. So this kind of extends into upper tracts as well, but we'll leave that for another day. So when the tumors form in the urinary system, when the pathologists look at them, there are a few criteria that comes into play when we plan the treatments, when we come up with the, all sorts of plans for this. So what they look at the arrangement of the cells. So urothelium is usually arranged in multiple layers, and they're very orderly. So this is kind of a cartoon of a normal urothelium. When the cancers are formed, but they're low grade, they start forming this disarranged kind of aggregates of the masses, and they are, they're kind of look different under the microscope, and that's how the pathologist determines them to be a low grade. As they become high grade, they become more disoriented and chaotic looking. The cells become bigger. And this is the criteria that, one of the criteria that the pathologists use to call this a high-grade tumor. As far as the staging, there are some, again, important structures and the pathologist, again, looks at it and gives us a report, urologist, the treating team. The high-grade cancer can sometimes form something called CIS, or carcinoma in situ, which is just localized in the urothelium. It doesn't go deep at all. Now, when they form papillary or nodular formations, they can grow outward, and they can also grow inward into the wall. So when they grow into the urothelium, but not deeper, they are stage TA. Once they start breaching into the lamina propria, they become stage T1. Once they hit the muscle, or the detrusor muscle, they become muscle-invasive bladder cancer, or T2, and then once they start growing through the whole wall of the bladder, they become T3. Some other important criteria we use when we talk about the bladder cancer is the grade and the histology of it. So 95% of the bladder cancers are urothelial. And that's based on the cell that is, composing the tumor and has gone haywire to start producing cancer. So here is just like a typical look for urothelial cancer. There is like a vessel core, fibrovascular core, and surrounded by these vessels. So 95% of the cancers are urothelial. About 5% of the cancers that we see are sometimes called variant histology, and this nomenclature has changed a little bit over time, but again, these are not the typical cancers. So another cancer that's a little bit more prevalent in this group is a squamous cell carcinoma, and this can be a pure squamous cell, or it can be just a little bit of a differentiation of the urothelial cells. It just has a different look under the microscope. Adenocarcinoma, probably the second most common in this group, and the cells start forming glands. They have a different behavior. Again, it can be pure adenocarcinoma. It can be urothelial with a little bit of an adenocarcinoma component. And then another one is the small cell carcinoma. These cancers are populated by very different cells, neuroendocrine cells. They have a very different behavior, and they look very differently under the microscope. There are some other types of cancers that are much more rare, and again, I don't think it's worthwhile to delve into those. Now, some more basics about bladder cancer. It is the 9th most common cancer worldwide. Affects both men and women. Only a minority of it, or 30%, is usually advanced at presentations, meaning it touches the muscle, MIBC. And majority of it that we see is non-muscle invasive, and this is usually treated by removal, resection, and some intravesical instillations into the bladder, usually. The typical treatment for muscle-invasive bladder cancer is very different, and for some non-muscle invasive bladder cancer can be a radical cystectomy. We also use chemo or some immunotherapy or target therapy options, but a lot of the times we give chemotherapy before the surgery, and that improves the survival. So it's pretty much the standard of care. So why are we talking about radical cystectomy? It is a fairly morbid and difficult surgery to undergo. What it does, a lot of people will experience some sort of a postoperative complication around the time of surgery, so about 60% morbidity. The reported rate of dying at the time of surgery or shortly thereafter is about 5 to 10%. And it profoundly alters the quality of life of the patients, both in the short term and in the long term. So we always want to look to alternatives to cystectomy if we can. And there are a few modalities that can be employed in this space. One of them is a Trimodality bladder preservation, and I'll speak about each of them a little bit more on the subsequent slides. Another one is a partial cystectomy. And then there are single modality treatments, including resection alone, radiation alone, or systemic treatments. And the systemic treatments, as I alluded to before, can consist of chemotherapy, immunotherapy, or targeted therapies. To speak about the trimodality therapy a little bit more, this is truly a multidisciplinary treatment. It involves a surgeon, involves a medical oncologist and radiation oncologist. What is paramount to success of it is a maximal resection of the tumor, so liquidation of the tumor, usually via resection. And then patients are given chemotherapy, and then they're getting radiation on the top of that. When given properly and properly selected patients, survival and disease control can be very similar to radical cystectomy. This is truly an underutilized treatment, and you'll find out why, but mostly selection is the key to the success of this procedure, and we just have to select the patients properly. Now, when we talk about the selection of the patients, this is what I mean by that. We know that there are some candidates that are not going to do well with this treatment, and these are the patients usually who have hydronephrosis. So the kidney that's normal and the kidney on the other side has hydronephrosis, meaning it's swollen, and the urine is backing up into it. And the reason we think that might be the issue is it may indicate more advanced disease than meets the eye. Presence of CIS, or as you remember, those flat tumors in the urothelium, makes the trimodality treatments not as effective. CIS is not very responsive to trimodality. Having large and multifocal tumors, as you see in the bladder, that's full of tumor, and tumors that are unable to be incompletely resected, also usually does not present a good outcome from the trimodality. And then the variant histology, even though there are some reports of people with variant histology responding to these treatments, we usually tend to think that they're not the best candidates for that. Additionally, there are multiple chemotherapy regimens. There are a lot of different radiation protocols that are employed in this treatment. Moving on to partial cystectomy. So in partial cystectomy, what we do, we go on and remove the tumor from the bladder, and we close the bladder off. It's also a little bit of an underutilized modality, just because we had some old studies that showed the survival was fairly poor, about 25 to 48%, and local recurrences were fairly high, up to 78%. So when there was more of a kind of thought about the patient selection, newer studies have given us better understanding of who would be the better candidate for this. So we know patients with solitary tumors, smaller tumors, less than 5 centimeters, and those are located in diverticulum, which are like these little outpouchings from the bladder, like the Mickey Mouse ears, would be served reasonably well with partial cystectomy. So for the newer studies, the survival has improved. It's about 54 to 70%, and local recurrence is much less, is 19 to 38%. These studies obviously haven't factored in some systemic treatment modalities and radiation, so this might be a field of future research to see how to improve these kinds of rates with more systemic treatments. So moving on to the single modalities, we have the TURBT, or transurethral resection of bladder tumor alone, and it's not a typical treatment that we employ for patients. It's only applicable to a very select group. Usually those are the patients who are too frail to go through other treatments. The success of this also depends on the ability to remove the whole tumor. The tumor has to be removed widely and deep enough, and what we use as a surrogate for a good quality of resection is presence of the muscle, which tells you that the surgeon went in deep enough and got out as much tumor as possible. With this modality, just like a lot of them, close surveillance is necessary to ensure the success. Radiation therapy alone. This is, again, usually not employed as a single modality, and it's usually given in the context of patients who have severe symptoms such as bleeding from the bladder, such as a lot of pain, and they are too frail to undergo any sort of surgery or chemotherapy. Another patient cohort that can benefit from this are usually patients with metastatic disease, but those that have symptoms from their bladder that's full of tumor. The outcomes are generally poor, as reported. However, that's probably because of the patients that are receiving this radiation. So it's a bit of a selection bias there. Survival is reported as 11 to 50%, depending on the study. So how can we make this better? We have a lot of research looking at the biomarkers and patient selection, and that's kind of the way of the future to let us know who's going to do well with bladder preservation. As far as the biomarkers, there are a few fairly large-scale studies looking at the ability to preserve the bladder and genes that are associated with it. So 3 big trials, HCRN, Retain, and Alliance. These all have a little bit of a different chemotherapy regimen. As I said, there is not a standardized chemo regimen for any of these. One looks at the gemcitabine and cisplatin with immunotherapy and nivolumab. One has to do with the DDM-VAC, or accelerated four-drug regimen. One is accelerated GC, gemcitabine and cisplatin, or the regular. And these genes are usually something we call DDR genes. So genes are responsible for DNA damage repair and monitoring. So we'll hopefully have some information coming soon from these. So shifting gears a little bit, going on to the radical cystectomy, which is more of the traditional way to manage the, like I said, the muscle-invasive bladder cancer. Here's just a brief anatomy of the male and female pelvis. There are some parts that are removed in both men and women, and because the anatomy is different, there are also differences of how we do the surgery for men and women. So as a standard for both men and women, we remove the bladder and remove the pelvic lymph nodes that are all around the pelvis. Now the differences start in men because the bladder is located very close to the prostate that the urethra traverses through. Going back. The prostate is routinely removed with seminal vesicles at the time of the surgery. Now for women, as I mentioned before, uterus sits right behind the bladder. So the uterus and cervix and ovaries, which are nearby, and anterior vaginal wall, which is the wall that is adjacent to the back wall of the bladder, have been fairly routinely removed. Also the urethra, because it's short, it's also routinely removed during the surgery. Now, why do we need to remove all these organs? And let's talk a little bit about the organ-sparing radical cystectomy. So let's start with men. The prostate, as I said, is routinely removed in radical cystectomy. And, we think that preservation of the prostate is understudied and underutilized. What we know from some older studies is that preserving prostate preserves the oncological outcomes when the patients are selected properly. We know that risk of involvement of prostate by bladder cancer is fairly low. And patients who have been reported in the past to have undergone this type of surgery, the new incidence of prostate cancer, which is separate from bladder cancer, is fairly low as well. Now, there is a myriad of benefits, functional benefits from leaving the prostate in place. So most importantly, let's talk about the erections. So we know that the removal of prostate causes erectile dysfunction, and the reason it happens because the neurovascular bundles, which are the nerves and the vessels that supply the sensation, the ability to have erection, and the blood supply to penis, they travel very close to the capsule of the prostate. So you see this is the capsule, the outer shell. There is the meat of the prostate, and the urethra travels kind of in the middle of it. So you see the nerves are just pretty much hugging the prostate there. When we move the nerves out of the way, even when we spare the nerves, there is a high incidence of erectile dysfunction, and this is reported to be up to 80%. When we spare the prostate and we leave the shell of the prostate intact with these neurovascular bundles, we see the complete opposite, about 86 to 89% preservation of erections. So, good outcome. Urinary benefits from sparing prostate are not, necessarily generalizable to a lot of the patients who undergo the surgery, but patients who have a neobladder, which is the bladder that's made from the small bowel and attached to the urethra. These are the patients who benefit from preservation of these. We know when the prostate is not preserved, the daytime incontinence, or ability to hold the urine, is about 92%, and the nighttime incontinence is about 50%. When the prostate is preserved, we have much better both daytime and nighttime incontinence. So daytime incontinence or continence goes up to 96%. The nighttime continence is the one that's improved the most, so it goes up to 82%. So men don't wet the bed. Candidates for prostate sparing, we are still, not at the level to point the finger and say, this is exactly the person who's going to be the best suited for this. But from the past studies, we know that good candidates are those that don't have cancer in the prostatic urethra, and they don't have cancer at the edge of the bladder joining the prostate. And usually these are the patients who have to be screened for risk of prostate cancer. So patients, the PSA and the imaging tests and the family history, these are all taken into account. So let's talk about women. Bladder, uterus, the front wall of the vagina. Some pelvic organ sparing approaches have been used since early 2000s. Sadly, only about 40% of the providers talk to women about sparing these organs, which is, it's hard to explain. We know that women who have organ preservation and are selected properly have good oncological outcomes, so it doesn't compromise their cure. And they have improved functional outcomes as well. Starting with the ovaries, so why spare ovaries? We know that the cancer risk in ovaries is low. Patients with no history of hereditary breast or ovarian cancer and absence of genes that predispose them to developing ovarian cancer have a low risk of this. And we know that the bladder cancer usually does not go to the ovaries, so very low risk there. Now, consequences of the ovarian removal are, they're not trivial. About 13% increase in overall mortality from premature menopause, increased risk of mood disorders, and even in postmenopausal women, and increased rates of osteoporosis. We think that even in postmenopausal women, ovaries continue to secrete small amount of hormones there. There is also shown sexual dysfunction in both pre- and postmenopausal women. Sparing the uterus and vaginal wall. Why do we talk about it? If we don't remove these organs, people usually end up with a better pelvic organ support. There is a decreased risk of vaginal fistula when vaginal wall is spared, and vaginal fistula is usually abnormal connection between the abdomen and the external cavities. There is less disturbance to pelvic nerves, and I'll show a little bit more about the pelvic nerves. And there is improved continence in women who also have a neobladder. So if you look again, daytime continence, if the organs are spared, it's about 88%. If they're not spared, it's about 63%. Nighttime continence, when the organs are spared, it's about 88%. When they're not spared, it's about 57%. And we think the nighttime and daytime is because, the nighttime incontinence is much more involuntary, so there's not a whole lot of ability to squeeze the pelvic floor muscles to prevent this from happening. And, having a better pelvic support, having the prostate in place, those are the things that help you with the involuntary ability to guard the urine. Pelvic plexus in women is composed of something we call pelvic autonomic nerve fibers. They travel next to uterus and the vaginal wall, and they're responsible for some important functions, for both holding the urine in place, for being able to urinate, and also for sexual function and vaginal lubrication. And the last piece of this, the urethrectomy. So the urethra, as I said, is routinely removed in women, is not done in men routinely. So there's the short urethra in women, much longer urethra in men that goes through the prostate. We know that there is a very small risk of urethral involvement. It's reported about 2 to 16%. And we know that we can usually screen out, most of the time, the poor candidates for urethral preservation. Those would be the people who have tumor at the bladder neck and at the, have invasion into the vagina. So we think it can travel kind of laterally to involve the urethra. So excluding those patients, usually the outcomes are good from leaving the urethra in place. And the benefit of leaving urethra in place is to avoid disturbance, to clitoris and to the branches of pelvic plexus. And these are the nerves, as I said, that help with the sexual sensation and with the lubrication. So this all translates into functional outcomes. So the conclusions I wanted to leave you with, I think it's time we all get out of the box and start looking outside of the box, because the view is better and we can see more things. And radical cystectomy is not the only option for bladder cancer treatment or invasive bladder cancer treatment. We have organ-sparing options that can be appropriate for some patients. We have a job as a medical provider, and patients also have a job as well, to improve the ability to kind of learn about these things. So we need to educate our patients on these options. We need to properly select our patients to do the best with the treatments we offer them. And, we also in, research kind of scheme of things, we need to develop better biomarkers to predict who's the best candidate for these treatments. So as patients, you need to obtain education, and don't ever hesitate to obtain a second opinion if something doesn't seem right, if you need more information, or just because. There's nothing wrong with that. So as a last slide, I wanted to kind of talk about the future of where I think the field is going, and just wanted to highlight a few of the studies we have here at Hopkins, especially the ones that I'm involved in. We have a study that looks at the more systematic way to garner knowledge about preservation of the prostate after time of cystectomy. We have a study that's looking at gender-related coping and survivorship for genitourinary cancers, especially bladder cancer. And then there is a multi-center study that is ongoing. It's been going on for about 1.5 years, and we're part of it as well, evaluating sexual function in women who are getting a radical cystectomy for bladder cancer. So with this, I am going to conclude my presentation. Thank you all, and I'm going to move on to the slide that allows us to have a conversation, and I can answer some questions for you. So we have a question that's coming through, and I can see, the question says, how do you know if you can have a partial cystectomy? So, like I said, not everybody is a good candidate for it, but a lot of the times people who have tumors that cannot be eradicated with a transurethral resection, the tumors that are localized to the diverticulum, so a small part of the bladder, the outpouching of the bladder, can be very good candidates for it. Now, whether these are the patients who need to have some chemotherapy or not, again, this becomes a little bit of more of an uncharted territory, but yes, there are some patients who are good candidates for that. Another question, does CIS absolutely rule out trimodality therapy? Is there some threshold that indicates possible user? When we think about the cost and benefit ratio of doing something for the patient, we have to, weigh, and again, pros and cons. So having CIS does not completely eradicate the possibility of trimodality therapy. But, if this is something that, ends up happening, there's a chance that the CIS is going to stay there and it's going to grow, and it will, turn into an invasive cancer. So that's why we usually don't recommend TMT in the presence of CIS. There are sometimes exceptions to the rule, and this is very much patient dependent. Another question is a radical cystectomy inevitable if one has high-grade bladder cancer? Well, it depends, again. For high-grade bladder cancer, if the patient has non-muscle invasive bladder cancer, it can be treated much easier by resections and intravesical treatments. If the high-grade bladder cancer does not respond to the conventional treatments, and if there is not a clinical trial that we think is appropriate for the patient, Sometimes these people will go on to have a cystectomy, but no, it's not just a one size kind of fits all. If you have a high-grade bladder cancer, you have to have a cystectomy. Role of immunotherapy alone in bladder cancer. It's a good question. We have a lot of studies that incorporate immunotherapy in different settings. We have studies that look at addition of immunotherapy to the standard chemotherapy regimens. We have studies that have resulted that, in FDA approval for immunotherapy in bladder cancer after surgery. Whether immunotherapy alone can treat the bladder cancer, that's a great question. I don't think we're there to give an answer yet. Maybe the future will show. Sometimes in patients who are not good candidates for chemotherapy because they're too frail, not good candidates for surgery because they're too frail, immunotherapy can be used mostly for palliation or for prolonging their life. Can you talk about role of urogynecologist in care of bladder cancer patient? Role of pelvic floor therapist too. So traditionally, urogynecologists have not been part of the treatment team to treat the bladder cancer. They have their own kind of specialty and conditions that they treat. Sometimes patients, when they develop, urinary continence issues or anything of that nature, can be referred to your gynecologist for some treatments. Pelvic floor therapists are very routinely employed in patients who have a neobladder, just because I think they're very helpful in assessment and the exercises. Some of the exercises the patients do are Kegel exercises, and those are notoriously hard to kind of figure out how to do on your own. So they become a routine treatment, part of the treatment team, and they're very valuable for that. Are there any other surgeries for resecting besides TURBT? The TURBT is a type of a resection that employs electric current to eradicate the tumor. There are a few different techniques of doing a TURBT, all using electric current. There are some reports of using laser to kind of remove the tumor, although it does not have any big advantage over just using electric cautery. So, when we're limited to inside of the bladder, usually TURBT is the way to go. When we're trying to be more creative and remove a tumor without disturbing the whole bladder, usually partial cystectomy is the way. How much difference is there between atypical and suspicious cytology? Can you have suspicious for 4 years and have no recurrence? I wish, we had the ability to avoid these ambiguous situations, and occasionally we come across these clinical scenarios, and I think it's not easy for a clinician and it's not easy for the patient to have this kind of a diagnosis. So cytology is usually, we present the pathologist with a liquid, and they suspend it and they look at the floating cells, and they look at the features of these cells and tell us how suspicious they look to them. So they don't report low grade usually, and the only thing that's reported, if they really feel that this looks like cancer, high grade cancer, they would call it a high grade cancer. A lot of the times, atypia can be promoted by such conditions as recent intravesical therapy, as any sort of inflammation, as any sort of infection. I think it's a little bit of personal paradigm and the faith in a pathologist, but atypia, I personally, a lot of the times, do not regard as a presence of cancer, just because there's so many conditions that can make it the cells look abnormal. Suspicious cytology, I think I would take it a little bit more seriously, just because it seems to be, a step above the atypia. And there are, some molecular tests that are used in bladder cancer that can be employed for these types of situations. So I think, again, it's a kind of personal situation. Have to look at the context, but this is kind of just the outline for the cytology. Assuming BCG becomes available, can it be alternated with gemcitabine and docetaxel to get the best of both worlds? Great question. Don't have the answer for that yet. We have become very creative in the times of BCG shortage. We have altered our BCG protocols to accommodate the shortage. Luckily, it seems to be kind of weaning off the shortage at the moment. We have a trial to see if the BCG is equivalent to gemcitabine and docetaxel treatments that are ongoing in Baltimore here, and I'm not really sure if it's a multi-center as well. I think other institutions are looking at it as well. The thing with the BCG, the effect of the BCG is based on the immune response of the body. And some people mount a great immune response and clear the cancer, and some cancers are more responsive and some cancers are less responsive. Now, if we mix and match BCG and chemotherapy, it's hard to know how the outcome will be. A lot of the times, if patients don't respond to BCG, we put them on chemotherapy and vice versa. And I think, you have to also consider the morbidity of adding multiple treatments in a situation when sometimes things are not needed. But this might be just a topic for future research as well. With non-invasive high-grade papillary carcinoma, is BCG the most effective treatment now? How much time is given for treatment? High-grade papillary carcinoma in BCG, again, another hot topic. The mainstay of the treatment for these papillary tumors is the complete resection. So if you go in there and you give BCG to a patient who has tumors in the bladder without removing them, we know that the effect of BCG will be definitely less. So with the complete resection, BCG still continues to be the gold standard or recommended standard for the high-grade cancers. However, there are some chemotherapy regimens that are compelling. And I said we have the Bridge trial that looks at the gemcitabine and docetaxel as an alternative to BCG, and we should have some answers. How does cisplatin shortage impact your treatment plans? I was not even aware of the cisplatin shortage until a couple of weeks ago when one of our medical oncology colleagues sent me a text about it. So apparently it's a thing, and it really does kind of change the way patients are treated. Cisplatin has been the mainstay of chemotherapy for bladder cancer. However, we have some treatment regimens that employ carboplatin or other treatment regimens. So I think it's not the end of the world. People get creative, and hopefully the cisplatin shortage will resolve soon. Are there any differences in your information that would apply specifically to the micropapillary cancer variant? So micropapillary cancer is one of these cancers that is considered a variant histology. Much more aggressive than the usual urothelial cancer that we see. Sometimes it's also underdiagnosed. If you have a micropapillary cancer, you want to make sure the pathologist that looked at the slides is fairly confident that it is what it is. Usually for micropapillary cancer, we would not try to preserve the bladder unless it was superficial. Whether it would impact the organ preservation, again, I think it would be dictated more by the location of the tumor and the stage of the tumor than the variant itself. Again, I think most of us would be much more aggressive when we treat the micropapillary cancer. What molecular tests do you routinely order for your suspicious cytology patients? So there's a myriad of molecular liquid biopsy testing that's been around for years. Cytology is kind of the one that we go to most of the time, and if it fails us, we have the options, as I mentioned. We have FISH testing that looks at the chromosomal rearrangements. There is a NMP22, which I haven't seen being used very much. There is CX bladder. There are a few more that are in production. All of these tests have some value, have some positive predictive ability, and sometimes give us some false information. I think, the availability of the testing kind of dictates whichever one you go to. If you look at the numbers for these tests, the accuracy of them is kind of fairly equivalent. So I think it ends up being a dealer's choice. Can we use nanoparticular magnetic induction hyperthermia for the treatment of the CIS? There have been quite a few studies to look at the cancers that are not responsive to the conventional treatments. So high-grade or high-risk cancers such as CIS is one of them. The nanoparticles have been employed in a few different situations, and the hyperthermia has been employed in a few different kind of situations, some of the trials. And I think combining these results, might result in a new trial. But there are some encouraging reports from both the utilization of nanoparticles, some utilization of the hyperthermia, and ability to enhance the chemo penetration into the bladder wall and make the outcomes better. Can someone have both high-grade and low-grade simultaneously? Another good questions. All good questions. I'm actually very impressed. I'm going to take a sip of water before I move on. It's like a rapid fire. It's not a common situation, but there are a few scenarios that this can happen. So the reason we don't see this happen very frequently is because high-grade cancers have a different mutational pattern that makes them be high-grade, and low-grade cancers have a different mutational burden that makes them turn into low-grade cancers. Now, the whole bladder is obviously a subject to some mutation that caused the cancers to form. And how these, the tumor, or how does the lining react to the insult is a little bit different. So there are a lot of cells. Yes, some of them can be low grade, some of them can be high grade, although it's rare. Most of the time, what we see is, all high grade and recurrences are all high grade, and low grade and all recurrences are low grade. And sometimes you can see a switch. There is a entity that was present before. It used to be called grade 2 bladder cancer. So back in the day, bladder cancer, instead of being high grade and low grade, used to be grade 1, 2, and 3. So when the pathologist reclassified that information, grade 1 became the low grade, grade 2 became the high grade. Grade 3 became the high grade. Grade 2 has become kind of this, weird entity. But I think, one can think of this situation when there is a high grade and low grade cancers as a grade 2. So pathologists sometimes will report it as majority of low grade with the focus of high grade. So I've seen that before, not a very common situation, but it happens. We have read about androgen receptor role in bladder cancer. Could we, in near future, find a target treatment? So androgen receptor has been implicated in the aggressiveness of the bladder cancer in the lab. I've had some research that was involved in looking at that as well. So I can tell you, a lot of the times things that are under the microscope or that are in animals don't end up translating into real world or human, change in the treatment paradigms. I remember there was a trial that has finished accruing, and I don't know the results of it, which makes me feel like the antigen or the receptor modulation was not as significant in the clinical scenario. But yes, when we look in the lab and the preclinical models, androgen receptor is definitely implicated in both the grade and aggressiveness of bladder cancer. Can organ preservation be done via robotic surgery? Yes, absolutely. Robotic surgery and open surgery are kind of the same extension of the surgeon. So whatever can be done open can be done robotically as well. And whether it's preserving the prostate, whether it's preserving the female GYN organs, both possible. Do you think Adstiladrin is a compelling alternative to BCG? Have you heard when it will be generally available? Some of these newer treatments that have been very promising and ended up with the approval are kind of, pending the ability of manufacturer to produce it in a mass fashion to be able to distribute to the public for general use. I do not know when it will be available. I know that the data from Adstiladrin is fairly compelling, so hopefully soon. Why is CIS high grade if it's not invasive? So if you remember my picture, the high grade and low grade are fairly different distinction than invasive and non-invasive. So grade is denotes the biology of the tumor. So aggressive looking ones are high grade. And the invasiveness is the stage of the tumor. So CIS usually kind of sits on the top of the bladder in the urothelium. It has not grown into the bladder wall. Now, if you wait long enough, CIS will become invasive, and that's why we try to eradicate it before it becomes invasive. What factors go into determining if your risk for breast or ovarian cancer are high? So these are usually, we try to get a clue from the patients based on their family history. So if you have multiple relatives with breast cancer, ovarian cancer, those would be the patients who might be at increased risk for developing these cancers themselves. Role of VRADs in detecting MIBC. I'm presuming this is pertaining to the MRI of the bladder. We do have a multi-parametric regimens for bladder imaging, similar to kind of MRI multi-parametric regimens that we have adopted for prostate cancer detection and treatment. We think that MRI can a lot of the times accurately predict the invasiveness of the bladder cancer, so whether it's in the muscle or not. The biggest trick with doing the multi-parametric MRIs is catching the patient at the right time. A lot of the times you have to wait 6 weeks after the resection, or this has to be done before the resection, because any sort of a surgical changes in the bladder wall will make the MRI less reliable. But yes, if it's done properly by, with the proper protocols, with the radiologist who knows how to read it, there's a fairly good accuracy in predicting the MIBC or, higher stage of the bladder cancer. All right, so that was the last question. Thank you for joining us. Thank you for listening to me patiently. If you're interested in scheduling an appointment, I think there's information where you can do that. And it's been a pleasure trying to educate you all today. Thank you.